34-year-old male patient presented with us seeking for kidney transplantation. His end-stage kidney disease on peritoneal dialysis for 1 year due to unknown original kidney disease, with a relevant family history and medical history of hypertension for 2 years. In the beginning of January 2008, he underwent right iliac renal transplantation from his brother, 32 years, with same blood group. He had no history of blood transfusion prior to transplantation. HLA matching showed 3/6 mismatch with PRA plus 1.4% tolerant specific and plus 0%. The ischemia time was 40 minutes with immediate diuresis. The graft artery was anastomosed to the internal iliac artery end to end, and the graft vein was anastomosed to the external iliac vein end to side. With induction by basilicimat 20 milligrams at day 0 and day 4 with maintenance immune suppression FK and MMF steroid free. He had smooth early post-operative course, and after 15 days he was discharged with serum creatinine 1.2 and FK trough level 7 nanogram per ml. The graft Doppler showed perfect cortical perfusion with a resistive index 0.64 with patent graft artery and graft vein. The recent study, including MRA and MRU, was perfect. Renogram, so well functioning non-obstructive graft with GFR 80 ml per minute. After 10 days of discharge in the 21st days post-transplantation, he was readmitted by graft impairment from 1.2 to 3.2 milligram per deciliter, and with oliguria 0.3 liter per day. Urine analysis was free and FK level was accepted. He had no history of pre-renal factor or non-adherence to treatment. The graft Doppler shows subcortical hyperfusion with absent diastole all over graft zones, but with patent graft artery and graft. After starting empirical steroids, we proceed to graft biopsy. This low power, so 1 glomerulus, that's normal. Yes. And show moderate interstitial inflammatory infiltrates and dilated tubules with attenuation of its lining. This HLE slide show moderate interstitial inflammatory infiltrates I2 with dilatation of tubules with attenuation of lining and loss of brush water. This pulse stain show mild tubulitis, 2 to 3 lymphocytes with post-tubular affection. C4D staining was focally positive in this peritubular capillary and this. So the diagnosis was acute antibody ADN, the risk of acute antibody-mediated rejection with borderline rejection T1, I2, V0. In view of this, we continued our pulse steroid 1 gram for 3 days, and we started total volume plasma exchange for 5 sessions and give the patient rituximab 375 milligram per square meter surface area and adding the steroid as basal immune suppression. 1 day later, we were astonished by steroids of serum creatinine from 3.2 to 6.3 milligram per deciliter. This was associated with swelling of right lower limb and urea for 6 hours with tender graft. Doppler right lower limb swollen shows from both the right shafted femoral junction and right common femoral vein. The graft Doppler shows state subcortical hyperfusion with beta graft artery and absent diastole and the attenuation of the graft. In view of swelling of right lower limb and the attenuation of the venous wave, we proceed to MRV that showed totally thrombosed graft vein extending to the external iliac vein and femoral vein with sparing the IPC. So the final diagnosis was acute antibody-mediated rejection with borderline rejection associated with graft vein thrombosis. In view of graft vein thrombosis, we proceed to thrombophilia screening, including anticoagulin, IgM, IgG, lowest anticoagulant, protein C and S, and thrombin 3, leading factor 5, prothrombin, G mutation, and homocysteine levels that were normal. For graft vein thrombosis, we were either to proceed for systemic infusion of streptokinase followed by anticoagulation, or to locally interventionally inject streptokinase followed by anticoagulation, or for exploration and thrombectomy. The final decision was for regional injection of streptokinase followed by anticoagulation. Our senior interventional urologist, Dr. Tarek Yassi, proceeded for local injection of streptokinase 750,000 international unit bolus, followed by systemic infusion of streptokinase for 2 days, 800,000 international units per hour, followed by benzaprine 175 international per kg per day and warfarin for target INR 2.2 to 3. This is the procedure. He cannulates the femoral vein on the left side and then proceed to the external iliac vein on the left side and then left common iliac vein and then pass to the right common iliac vein and then to the external iliac vein and then to the graft vein and locally inject streptokinase. Angiography post procedure shows successful recanalization of the graft vein. The outcome showed perfect cortical perfusion with relative index from absent diastole to 78.78 with patent graft artery and graft After 7 days, the patient was discharged with serum creatinine from peak 8 to 1.1 milligram per deciliter and increased urine output from 0.3 liter to 3.5 liter. In the last follow-up in November 2014, he is free of anticoagulation after 1 year and serum creatinine 1.2 milligram per deciliter and total release were okay, total lower level is okay, and FK level was okay. Graft vein thrombosis is a devastating complication that results in either graft failure, rupture, or even mortality. And this is reported in incidence from 0.4 to 6% of renal transplant, mainly in the first 2 weeks post-transplantation. The patient is clinically presented with polyguanuria, unilateral leg swelling, like our case, azotemia, hematuria, and graft tenderness. The causes include either surgical problem in view of kink in the graft vein, narrowing at the anastomostic side, or compression of the graft vein from outside, graft rejection, and as in our case, and hypercoagulable states. The treatment modalities include either exploration and thrombectomy, or interventional thrombosuction and in-situ thrombolysis followed by anticoagulation, systemic infusion of thrombolytic agent followed by anticoagulation or graft infections. This is a paper published from Urology and Nephrology Center in June 2014 about vascular accident post-transplantation, published in International Journal of Urology 2014. This includes graft artery thrombosis in 19 patients from big 2,060 patients with percent 0.7%, and 12 cases were salvaged with percent 63%. And as regards to graft vein, there were 6 cases with incidence 0.2% less than the minimum worldwide. 2 patients were explored and underwent thrombectomy, 2 underwent exploration and nephrectomy, and 2 were salvaged by intervention thrombosis. Thank you.
Thank you, Dr. Ahmed. 3 minutes discussion.
The duration between intervention and recurrence from those, how much? How long?
And the occurrence of thrombosis?
Yes.
6 hours with occurrence and diagnosis of
intervention was 6 hours.
Yes.
Thank you.
هو الثرومبوزيس ده حصل كفاسكولار انسس
ولا complication rejection؟
Complication rejection mainly.
بس انا كنت شايف الريجكشن سنت دكتور ماهر it is association. In this case it was associated with antibody-mediated rejection. We have a basal Doppler study, and we are presenting this case to transfer the message of the importance of monitoring by Doppler ultrasound, because at first presentation the patient is polyguanular and the Doppler ultrasound showed normal and patent renal vein. It may be related to rejection, we are not sure. But of course, theoretically, we have to treat the original process. We treated rejection, but still we have here.
لا طبعا هعالج الاثنين، بس هو الفكره انه في البرزنتيشن ما حسيتش انه الثرومبوزيس ريليتد قوي للريجكشن. يعني probably it is an association rather than a complication in rejection.
بس جت بعدها، المهم انها جت بعدها. جت بعدها.
جت بعدها
Doppler at presentation with serum creatinine 3.2 from 1.2 was normal and patient graft artery and graft vein. But after swelling of the lateral limb, we did another Doppler that showed attenuated graft.
طيب بس البيوبسي باين لك ان في ريجكشن.
Rejection.
يبقى ده معناها ان ده حصل بعدين.
بالظبط.
دكتور عمر.
هو الحقيقه كليرلي حضرتك قلت الكوزز اوف رينال فين ثرومبوزس، وقبل العمليه واثناء العمليه وبعد العمليه كله كان كويس. وفيليا ما عندوش، هو كليرلي الريجكشن عمل ثرومبوز، ودي حاجه وارده طبعا. بس العقل ده يعني يخلينا نفكر شويه في الاسترويد في ريجيم، مش كده ولا انا عملت سلايد بس عشان تخفف البتاع دي. الاسترويد في ريجيم نتائجه ايه يعني اذا كان الاسترويد في ريجيم بيجيب حاجات كده احيانا، لا بصراحه يجيبوا دايابيتس بعد سنه احسن.
There is no ideal regimen.
هو الاسترويدز بتجيب دي في تي.
معلش
one of the complications
بس ده جاب له ريجكشن، يعني مش دي في تي، هو الدي في تي جه نتيجه الريجكشن.
لا I think
In this patient, I cannot imagine that if this patient was treated with initially with triple therapy with steroid, the antibody-mediated rejection will not happen. We have patients on triple immunosuppressive therapy and we have severe antibody-mediated rejection.
سلايد فيه
آخر سؤال.
Did you monitor later on on the spot of the rejection for anti-nuclear antibodies?
We did not monitor.
يعني ده يعني البروبلم كلها عندي اندوثيليال بروبلم، وفي انتي بوديز بتسلكت الفينز اكتر من الارترز واكتر ساعات الارترز اكتر من الفينز. انت عندك ايفنت هنا مش واخده الكابيلز، مش واخده الارترز، واخده الفينز. and you should monitor for anti-endothelial antibodies with donor specific antibodies وتمونيتور later on بالnext screening every 3 months او اي حاجه، لان ده critical situation.
Thank you, Dr. Ahmed.